Bowel cancer is the third commonest cancer in the UK and the second biggest cause of cancer death in the United Kingdom. If you catch it at its earliest stage, you have an over 90% chance of being cured by surgery. Therefore, it's critical to make the diagnosis as early as possible. The way we diagnose it is with colonoscopy. It's a very accurate way of diagnosing bowel cancer, but we don't have unlimited capacity with colonoscopy, so it's critical that we focus the available colonoscopy that we have on the right groups of individuals. The difficulty with relying on symptoms to predict the presence of cancer or not is that symptoms have a very low yield, and only about 4% of people with symptoms suggestive of bowel cancer will actually have bowel cancer. So to put that another way, 96% of the procedures we do will be normal. Now that's great for the patient, obviously, but it means we're spending a lot of time investigating people where arguably it's not necessary. And that's got massive resource implications for the NHS, and anything we can do to reduce that has to be a good thing. FIT replaced the old-fashioned guaiac FOB test. The main difference between the FIT test and the FOB test is, number one, the FIT test is much easier to use for the patient. Secondly, it's quantitative, so it gives you a number rather than just a positive or a negative result. And thirdly, it's a lot more sensitive and specific. So if your FIT test is less than 10, you can be reassured that you have an over 99% chance of not having cancer, and that's obviously immensely reassuring. So what we can use this data to do is concentrate our limited colonoscopy resource on investigating the patients who have a FIT greater than 10. And for this reason, FIT is a really useful triage tool when you're assessing somebody with colorectal symptoms.
Any patient who complains of bowel symptoms should be offered the FIT test. So they may come to you and talk about very obvious symptoms like a mass in the abdomen, or they might have symptoms that are less clear. But if you have a look at our pathway, you'll see that we describe the symptoms falling into NG12 or DG30 guidelines. For both those sets of patients, a FIT test is appropriate. So to order the FIT test, it's really simple. So within EMIS, come to Test Request menu on the left-hand side. We go to Online Test Request and choose your local hospital. Pop down to the bottom, press Pathology Search, and then in the search bar, type FIT or faecal. That will bring up 3 options, one of which is fecal occult blood. Click on that, press Add, and close that menu. Then you come up to the top here, you'll see there's an opportunity to put some clinical details in, which you need to do. So this patient was presenting with abdominal pain. And then pop down to the end of the menu and finish. It asks you, are you happy that you've done the request correctly? And then in a second, you have an option to print.
For the laboratory to process the sample, it must have the patient's full name, their date of birth and NHS number. The patient's NHS number will be on the request form that is given to them, and it's really important that they also send that request form back with the sample so we know which test to do. Once the laboratory has done the analysis, the results will be returned within 5 working days to the requesting GP.
So let's think about how we interpret FIT results. The first thing to do from a clinician's perspective is to be clear whether you're considering a patient on the DG30 pathway or the NG12 pathway. For DG30 patients, if their FIT test result comes back at less than 10, they can be safety netted within primary care. Usually they don't need any further investigations, just reassurance. Of course, if the patient came back with new symptoms or progressively more serious symptoms, then that would be a reason to repeat the FIT test. So with DG30 patients that return a FIT test more than 10, those patients will of course need to be referred straight into the 2-week wait pathway. When we think of NG12 patients, if their FIT test comes back as more than 10, then of course they'll be dealt with on the 2-week wait pathway. On the other hand, if their FIT test is less than 10, then you need to refer them into the FIT less than 10 NG12 follow-up clinic in the hospital of their choice. There's a referral form for this on Bar Global in the EMIS system.
This is a new pathway. It's a very low-risk pathway. Almost definitely the patient does not have colorectal cancer, but the patient will be safety netted by the hospital, and what that will involve is the patient being seen 8 to 10 weeks later with a repeat FIT test, a repeat full blood count, just to see if anemia has developed, and there will be a clinical assessment by a senior clinical decision maker.
So you may ask, why are patients who are on the NG12 pathway with a FIT under 10 being referred into a specialist follow-up clinic? We're doing this specifically for 1 year as a service evaluation project because the data from our research study has shown that we need to look more closely at these patients. Once a service evaluation is completed, we'll use the data and analytics that we get from that to inform both the local pathway and the pan-London pathway.
Our feeling is that this is a safe, reliable, high-quality way of ensuring that patients don't fall through the net and they're able to be given sufficient clinical reassurance that everything's okay.
If a patient becomes unexpectedly unwell during the time they're on the follow-up pathway, for example, their colorectal symptoms worsen, and it's decided that they need to move forward back into the 2-week wait pathway, then at that point, the GP will be informed that this has happened, so that if the patient wants to come and talk about it with you, then they can do.
There are particular circumstances when you wouldn't want to use FIT. So, for instance, in iron deficiency anemia, FIT is much less reliable and there is a greater risk of FIT missing cancer. So in that situation, they are referred on a standard 2-week wait pathway as they've always been, and there's no need to do a FIT. Similarly, very high-risk symptoms like presence of a mass or rectal or anal ulceration, again, they just get referred up. There's no need to do a FIT in those circumstances.
The FIT test can't be used in place of calprotectin for investigating patients for IBD or IBS. The tests look for 2 very different things. So QFIT is looking for blood in faeces, so it's looking for red cells. Calprotectin is looking for evidence of inflammatory disease, and it's looking for white cells.
You need to ask yourself, am I investigating or querying inflammation in the bowel, or am I investigating or querying tumour in the bowel? If I'm querying tumour, then I need to do a FIT test as a GP. If I'm querying inflammatory bowel disease, then I need to do a calprotectin test.
With rectal bleeding, what our local data tells us is that FIT is still reliable, but it's important to counsel your patient that rather than sampling blood on the stool, which will obviously return a positive FIT result, they either sample a non-bloody stool or they sample the stool away from the blood. And in that way you can get a representative FIT result that tells us what's going on in the rest of their colon.
So doctors and patients often ask, do we need to give a FIT test to a patient that's had a negative screening test? And the answer is, if they've presented to a doctor with symptoms, then yes, they do need a FIT test. And that's because the cut-off level is very different. It's a lower level to make sure that we avoid missing cancers.